My friend, good mornings, where you are, afternoon, and good evening. I am Dr. Muhammad Al Rouhani, consultant nephrologist, and today I will start my talk about the use of SGLT2 inhibitors in chronic kidney failure patients and circumstances around that. Uh, those group of medications is important, and there is a inertia in starting it and using it, especially in the nephrology area, uh, without explanation why we are late. Do we afraid, or do we have a lack of information about the side effect, or about when to start, when to stop, or we better trying to avoid any risky condition? I will try to make some point for internal medicine and for our colleague clear or refresh it to enhance the using of this group, important group, in our daily practice. First of all, I will speak about the consideration of using this group in type 2 diabetes and CKD as well. There is two sides to think about it. Either we think about the renoprotective with a good control of diabetes, or either we'll use it as a renoprotective as well, but with the need of glycemic and weight loss. So if I am looking to the patient when he is in need for cardiorenal protection and the glycemic is below 7 or below 6.5, I will think about the hypoglycemia, and I will consider insulin as sulfonylurea as a risk of hypoglycemia. And this will lead me to think about the dosage of insulin and how to modify the sulfonylurea group. It is recommended to decrease the insulin dose in general by 10 to 20% to avoid any risk of hypoglycemia, or to modify the oral sulfonylurea antidiabetic drugs. Second thing, in this group, I will look to the blood pressure. If the blood pressure is normal or mild elevated, I will be happy to start this group without risk of hypotension. This group is passing urine and passing glucose, as we know, and reduce taking water, and reduce the fluid volume in the body, leading to risk of dehydration. So I will look to the volemic status if this patient is hypervolemic or eupholemic, and I will look to that if to avoid if he is hypovolemic condition, how to encourage him to have enough fluid replacement. So in that condition, I will look really to the fluid, and I will look to the blood pressure, as we told, from the side of the medication. Medication is important point where to modify. If the patient is having diuretic, should we reduce the diuretic doses or remove it if necessary, but to keep the patient in RAS blocker to have a maximum effect and benefits in renal protection side and cardio protection side. If I have to look to the weight loss and the level of estimated GFR regarding the glycemia, I will tell that if the patient is above 60 milliliter per minute per meter square estimated GFR, I will have a good reduction of HbA1c up to 0.9, and I will have reduction in the weight up to 3 kilogram. What it is nice. When it is the estimated GFR or the GFR reduced, I will look to that in which stage. As you know, we are staging the renal the CKD. If it is between the 30 and 49, I will think about, or 59, sorry, 59, I will think about less effect in the glycemic control and less effect in in the body weight reduction up to 2 kilogram and up to 0.5 HbA1c. If it is less than 30, I will discuss it in a different slide, but better to avoid in general. So this is the consideration when I have to think when I will start this medication. I have also to remember that in kidney patient we have such condition where there is no answer in clinical trials, like solitary kidney. What to do? There is a hemodynamic change, we know it in the beginning. There is a drop in the level of estimated GFR, then stabilization and continuation of stabilization compared to the placebos coming from up down. So how much is this drop in a single kidney? What should I do? I prefer in that time to send from our internal medicine or primary healthcare, if they have a Dalai Lama and starting this, to send it to the nephrologist who will make the follow-up. Conditions like post-kidney transplantation, bilateral renal artery stenosis, severe lephorrhosis, and breastfeeding and pregnancy, better to avoid using this medication. Simply, for example, in bilateral renal artery stenosis, the theoretic effect of that is avoided, same as we avoided any other diuretic. So this is the point when we have to think about that with the infection. The infection is an important issue to avoid because to treat. But where? Simple infection can be treated by rehydration, by start early medication, by the hygienic habit and increasing the hygienic and the hygiene of the urogenital and genital in male and female equally. But when I have recurrent UTI, or I am expecting that this patient is going to use the catheter if he is inpatient, better to avoid using this medication. Also in admitted patient, we have to avoid in acute illness, any acute illness, regarding the fluid overload, and in the surgery. Better temporarily to hold this medication and to restart it after to avoid the DKA, because the DKA in that population is small, not that much, but it is a risk, and when it's happened, it is not easy and not welcome. It is just 0.16 to 0.76 per thousand per year patients. So better in that to avoid. There is also a talk about the when to stop this medication. Until now, canagliflozin, we can stop it when it is estimated GFR is 30 or below 30. Dapagliflozin, if it is 25 estimated GFR. Empagliflozin, until now we are in waiting for the new trial, CKD, to approve the use above or around 20 milliliter per minute estimated GFR. We have also to think about the electrolyte disbalance. Electrolyte disbalance is an important issue and discussed but not approved and not yet highlighted in the area, and it is mild, like hyperkalemia in CANA, hypermagnesemia in all, hyperphosphatemia in all. We have to think about that. Yes, there is a big trial study, but we have to think, to wait, and to look to that okay, if it is a minimum, we have not to afraid using it. So even in these stages or this recommendation, we have to increase the awareness of using medication, and I hope I give you important information or refreshment just to be more confident to use this medication continuously with brief heart. Thank you and have a nice time.